So, good evening, everyone. Welcome to the Seeing is Believing webinar, and thank you, everyone, for joining. So, I will go through Integris MedTech and our corporate presentation. Then we can proceed with Dr. Dannenberg presentation. So, if I talk about Integris MedTech, it is India's leading diversified MedTech platform for global emerging markets. The first arm of Integris MedTech is Everlife, which is a leading lab and analytical equipment platform in Southeastern Asia. If we talk about the second arm, it is Translumina, a leading cardiovascular solutions provider in emerging Asia and Europe market, along with partnership with Lamed and Blue Medical. If I talk about the overview of Integris MedTech, it is a diversified medtech platform with strong global reach, manufacturing facilities, and a unique partner acquire build model. We have different diversified portfolio in cardiovascular, in vitro diagnostics, as well as scientific lab solutions. We have leading market positions. We are number one player in scientific lab solutions in Southeast Asia. And in terms of stents, we are second largest stents player in India with around 18% market share in coronary stents. We have around 2000 plus hospitals and cath lab directly covered by us and around 350 plus distribution partners around 60 countries. If we talk about our strong R&D and manufacturing, we have 7 manufacturing centers in India and Europe combined, out of which 2 are specific R&D centers. If we talk about the cardiovascular division, we have polymer-free stents, we have advanced coronary drug-coated balloon named Protege, we have calcium modification technologies such as IVL and OPN. We also have intravascular imaging and physiological solutions with name Assist, and we also have in-house manufactured vascular accessories. With brand, we also have in-house manufacturing as well as we have certain tech transfer, distribution, and supply partnership with large MNCs all over globe, such as Shockwave, Sysmedical, Kanika, Asahi, Assist, and a lot more. So if we deep dive into Translumina, the interventional cardiology business of Integris MedTech, we are second largest stents player and domestic leader in India, around 18% stents volume if we talk about market share. With a global presence and strong clinical pedigree, we have distributor network in 50 plus countries with sales team of around 20 plus members. And we have, as I earlier also told, we have around 7 manufacturing facilities with 5 manufacturing plants and 2 plus R&D centers. So this is all about Translumina. Now we will go ahead with our, just let us. My screen is still visible, Supriya?
Yes, Ritik.
Yeah.
But can you put on slideshow?
Actually, I want to unshare. Okay.
Yeah.
Okay, just give me a second. So we are still waiting with our moderator, Dr. Mitendra. So since the time he will join, I will introduce with you everyone. So we have Dr. Ham Dannenberg from Hebrew University of Jerusalem, Israel. We also have our chairpersons, Dr. S. Ramesh from SRMC Hospital, and Dr. Raghav from RKM Hospital, Ambala. We have four speakers for today: Dr. Samuel from Frontier Lifeline Hospital, Dr. Raja Gopal from Avant BKG Hospital, Dr. Vidur Karnik from Rhythm Hospital, Kolhapur, and Dr. Hitesh Shah from Rajasthan Hospital, Ahmedabad. We also have four expert panelists today: Dr. R.S. Venkateshlu from Sparsh Hospital, Hennur, Dr. Anirudh Pratap Singh from SSMH Hospital, UP, Dr. Ripin Gupta from Max Delhi, and Dr. Ashish Agrawal from Indigo Hospital. So now we can proceed with Dr. Ham. Sir, you can carry on with your presentation now.
Can you see it now?
Yes,
Can you see
it's
the
visible, sir.
presentation? Okay, great.
You can put it on slideshow mode.
It's now in slideshow, at least for me.
Yes, perfect, sir.
Okay, so thank you for the invitation, and I would like to share with you a little my experience with the Elunir Pearl, or with the Forolimus eluting stent. As mentioned, my name is Chaim Dannenberg. I'm an interventional cardiology, head of the cath lab in Wolfson Medical Center, and a professor of cardiology in Tel Aviv University. And I'm truly privileged as a great friend of the Indian cardiology. I've been visiting India several times, always happy to share my experience and learn from yours. So today I will present a little the new drug-eluting stent, the Elunir Pearl. The Elunir Pearl is a drug-eluting stent which I'm very familiar with, since this is the workhorse in my cath lab. We're using it a lot, actually in every case, and we've learned to be very fond of this device. It's a very conformable stent, and I'll speak a little bit about the proprietary Weissel's technology, highly deliverable, and a very safe stent, drug-eluting stent to use. And therefore, as I mentioned, it became indeed our workhorse. The unique features are indeed the visibility. The stent provides radiopaque markers that are incorporated into the stent in both tips, make it a highly visible and exceptionally well for bifurcations, for ostial lesions in which we need to be very, very precise. As mentioned, due to the new hybrid metal spring tip, which is covered by nylon jacket, there is a very short metal tip design with very low tip profile, and therefore no friction, highly deliverable. And indeed, several studies already showed that it's a very successful to use, and I'll share the experience as well. The bare metal frame, the platform, is made of cobalt chromium, L605 cobalt chromium alloy, on which there is a coating of a blend of carboxyl and poly and butyl. It's called PBMA. That's the polymer. And on this polymer, a new drug is which from the Linus family is loaded, and this is the Ridaforolimus with a kind of very tiny amount of drug. What the Ridaforolimus have a very elegant therapeutic window, difference between its inhibition of smooth muscle cells and endothelial cells, and therefore make it a very effective while highly with a high safe profile for this drug. As you can see here, in comparison with everolimus, in which the endothelial cells are low dose is effective on endothelial cells, here you need a higher dose to affect the endothelial cells, while you can inhibit smooth muscle cell proliferation, which is actually our goal. The strata ultra narrow. There are struts of two different sizes, 40 and 72 microns, as compared, you can see here, to Zions, in which it's 95, or Resolute Onyx 96. Here it's thinner than both, and you can see there's a mixture of the ultra thin, ultra narrow, and narrow width struts, all promoting halo, all promoting healing. The metal to artery ratio, the metal footprint, is indeed a very low one. Yet, although it's very thin, the stent is a very conformable one. The size, the cells stays at the same size, even in a highly bended arteries. When deployed in a curve, other stents leave large gaps. The Elunir Pearl stays quite the same. And you can see here comparison with the actually all stents that are in use here in Israel. And the Weissel scaffolding keeps the size actually constant, uniform, without getting large in curves, and therefore the amount of drug that is deployed at these areas stays constant. And you can see here the Elunir Pearl stays contrast, the drug deposition is contrast, there is no under or overdosing, while in competitor drug-eluting stents, some areas, the inner curvature is overdosed, while the outer curve is underdosed. And in addition to the very modern scaffolding and the radio-opaque markers, the tip is a very low tip entry profile, very low friction, and therefore highly deliverable, make it an outstanding to use in tortuous arteries, highly calcified arteries, and I'll show some examples in a few minutes. As I mentioned, the markers are not all at the same line, and therefore you can see them from any angle you take, the markers on both tips. A very important feature that once you get used to having those markers, it's very hard to work without. So enhanced metal spring tip, low tip entry profile, reduced tip friction with the nylon covered jacket, and improved radio opacity. The spring tip, it's quite important to understand. When you go on a wire in a very sharp bend, the tip in most delivery system form this fish mouth, which increase the friction. As you can see here, this is the Zions, Synergy, and even the Resolute Onyx. Here, the new tip design refrains from having this fish mouth, and therefore improve the deliverability. I mentioned the visibility. You can see here this proximal LED lesion deployed, and post standing and post dilatation. You can see here the markers, and if you can't see them here it is in front of you, and we can see the markers on the proximal and distal sides, and we know exactly where the stent was deployed. The manufacturing, and this is Medinol, an Israeli company, truly a high-tech company with extremely modern both design and manufacturing. The stents are laser cut from a stent panel with automated visual inspection of the stent panels and elastomeric coating. And it's not just words. When you need to cut a stent which is already cylindrical, it is much harder and less accurate than cutting on a flat panel. And when you're trying to coat this with both polymer and drug, much easier, much uniform when this is done on a flat panel as compared to try to cover a stent which is cylindrical or round. Here, definitely you'll end up with more coating here than on the distal surface. Coating of a round is definitely less accurate than coating a flat surface and then creating the stent. And as you'll see here in a minute, the elastomeric polymer and this deposition in a flat panel make it much more uniform with less deformations, less webbing, cracking, peeling as compared. And these are electron microscopy of the stent. You can see here how uniform is the surface of the Elunir Pearl as compared with its competitors. I'll be very short with the clinical update. Two large studies have tested or assessed the function, safety, and efficacy of the Elunir Pearl as compared with the leading stent here in Israel at that time, the Resolute. And as you can see here, target lesion failure was actually similar between the Elunir and the Resolute. This was a randomized controlled trial. Stent thrombosis was somewhat lower with the Elunir Pearl as compared with the Resolute, not reaching statistical significance since it was very low numbers in both groups. The Resolute is a very safe stent as well, and yet the Elunir numbers were even lower. The results were persistent at 1 and 2 years, and as you can see are actually similar between the Elunir and the Resolute. MACE was somewhat lower and yet not reaching statistical significance, showing indeed that both stents are very modern one, but that the Elunir is definitely not inferior, and if anything, maybe even better than the Resolute. Late lumen loss was similar. Tissue target lesion failure in MACE at 12 months, again, somewhat numerically lower, but not more than that. There was a small part of the Bionics trial, which was the Nireos with a angiographic follow-up, and again, and you can see here the numbers. The study is of over 2,000 patients, and the numbers were again very fond of the efficacy and safety of the Elunir Pearl, with a very low number of stent thrombosis. This is the study with the angiographic follow-up. Another study was held in Japan. This is the Japanese Elunir clinical trial. Here, 104 patients were tested and compared with the control of the Bionic trial. It wasn't a randomized trial, but yet very leading centers in Japan. The results were again of showing very low target lesion failure, 1.9. It's not a randomized trial, and yet the results show the high efficacy and safety of this outstanding stent. Stent thrombosis, again, a very low one. So with your permission, I'll share with you some cases done in our lab. I try to choose some representative cases, and as I mentioned, every day we're doing at least 6-7 patients are treated with the Elunir, if no more than that. So here is a young gentleman, 56-year-old guy, heavy smoker, suffering from chronic obstructive lung disease as well, admitted with acute coronary syndrome, elevated troponin. And actually the arteries look quite well. Sorry, I apologize. Other than this lesion at the ostium of the LAD. And actually, we even discussed the option of bypass surgery, of bypassing with a Lima. But due to the, let me show you. You can see here, I think it's quite evident, the very ostial lesion of the LAD. due to the lung disease, we chose to treat him percutaneously. And here, definitely, the device of choice would be the Elunir Pearl, having its proximal and distal marker. And you can see here the 4 millimeter stent implanted. And this is post-stenting, and you can see here, you can be very accurate with this stent without obstructing or interfering with either the ramus or the ostial circ. I guess we can all agree that the result was a very favorable one. The patient was discharged the day after, and we're now at least 6 months following the procedure. It is doing very well. We definitely had to protect the circ with a wire, but other than this, and you can see here under high mag how accurate the Elunir Pearl allows you to be. Here's another case. Most of our patients are older than 56. In Israel, we treat very old patients. Here is an 86-year-old lady, diabetic, renal failure, post-PCI to the LAD and circ a couple of years ago, and admitted with unstable angina. We had to be very frugal with contrast. You can see here 3 lesions along the right coronary. And you can see here 3 Elunir pearls implanted, direct stenting, trying to be very frugal in contrast. You can see the proximal, the mid, and the distal here, ending up with less than 44. And I chose another case, which is quite the same. 85-year-old, treated 2 weeks ago. I just added this case. Here, the creatinine was even higher. We had to be very, very frugal with the contrast with this diabetic lady. This was the only lesion, surprisingly, but highly calcified artery, and yet a single stent, direct stenting. And this is the final result, ending up the whole procedure with 21 cc's of contrast, including the left coronary artery. And one final case, 71-year-old gentleman, diabetes, hypertension, extensive anterior STT changes, high troponin 600, our normal is up to 14. Second. And you can see here highly calcified LAD with several tandem lesions. 1, 2, and up to a third one distally. I think I have enough picture. You can see here how long is the lesion on the wire. We did predilatation here, and a single very long stent, Elunir Pearl, 3 millimeters on 44. And you can see here how uniform is the artery without disturbing or without hampering the diagonals or the septals, and that's the final result. I tried to enlarge it so you can see here single 44 millimeter stent. You can see the markers here and here covering the whole very long and calcified lesion. So in conclusion, the Elunir Pearl is indeed a leading stent with vision. The design, the elastomeric coating, the superior deliverability, and the outstanding being clinical outcomes make it an excellent choice in my cath lab, and I guess that in your cath lab in the very coming future. And I thank you all for allowing me to present this in front of you. And I'm open for questions. Thank you very much.
Thank you, Dr. Dannenberg. Good evening, Dr. Mitendra.
Hi, good evening. Sorry
Yes,
for
sir. So
delay. I
any
was
comments from your end? Yeah.
sir, excellent presentation, Dr. Dannenberg. And just one quick question that in patients with a CRF, how frequently do you use imaging, particularly IVUS, when you have CRF in your patients?
We're using IVUS between 5 to 10% of the cases in total. Definitely more I haven't shown in the patient that I've shown in the first case, we did an IVUS, of course. The left main was clean, and you can see an isolated lesion about 2
Yeah, so nailing
millimeters
the left main
from.
without imaging, that's what I was asking. Marker will help you, but the nailing the left main, just ostium of the LAD, so you may expect a disease in the future at
Yeah,
bifurcation.
definitely. Yeah,
So
we're
precisely
using.
imaging helps there.
Yeah, I didn't want to show here to make it, too heavy presentation, but of course, we perform in IVUS, and only after being sure that it's not a left main, it's not that we're not treating left mains, but in a 56-year-old gentleman, I would probably refrain of doing a percutaneous procedure, but rather refer to surgery. But if it's indeed an isolated, we've learned that we can be very accurate, especially having this marker-loaded stent.
Markers with this.
Yeah, and we've been using it again and again. It's a workhorse, so we're using it in combination with other stent, but we've got to use it more, and it became our default in bifurcation, in ostial lesions. Then definitely it's the number one stent to use. In addition, when you need, in some lesions, you're ought to do overlap between stents, either because of sizing or there's the one stent and you want to add another one here, definitely use the marker, use the Elunate Pearl. And having it so deliverable, so easy to use, as an operator, we learn to choose what's work for us. So
Yeah.
we're using it
We
more.
also find it very useful for overlap, particularly in ostial lesions when you have a large branch. So we would have preferred to, I think Dr. Rajiv is here, sorry, Dr. Ripin is here, and he will agree that we usually, although we had another issue, we had a big ramus in the first case. Otherwise, we would have gone from the left main to LAD rather than just nailing the LAD ostium. So what is your take on that?
Definitely. If it's an older patient, if it's only a bifurcation and not a trifurcation, then I would consider covering it all. But in a young patient, when I'm trying to think of the future, if I can nail the ostium, I'll do that. And I think we all learn that our decision making is different. For the same lesion, it may be different in different patients, different ages. And I think that in such a case, if you're successfully nailing the ostium, the patient definitely benefits from that.
So I think for the sake of the time, can we move for the second presentation or the second speaker? Case 1, real world scenario, PCI with redifferimus by Dr. Samuel Jacob. He's from Frontier Lifeline Hospital, I guess.
Yeah. Good evening, everyone.
Yeah.
I'm Dr. Sam. Actually, I'll just share my screen now. So this is one of the cases, actually in the last 2-3 months is when we started using Elunate, and we've been able to do quite a number of cases with Elunate. As I said, we have got pretty good use. We find it very easy to use. Is my screen visible? No problem with the screen, right?
Yes, sir.
Yeah.
It is.
Okay.
Yeah, it's
So
visible.
my case was a 61-year-old female, known hypertensive and diabetic. She had effort angina for the last 1 year, medically managed, not much of a problem. But over the last 1 month, she started developing, there was recent worsening of the angina. So the ECG and echo didn't show any findings. And we just thought, okay, since there's a recent worsening, we'll take her for an angio. And this is what the angio showed. So it was a LADD1 bifurcation lesion, 111 Medina. So I'll just quickly run through the angio. And that was the D1 also being pretty big, actually looked like a dual LED system. Uh, yeah. So we went ahead, wired both the LED and D1, and then pre-dilated both of them with a 2 into 12 millimeter balloon. And after that, uh, yeah, why is it playing the same thing? All right. So this is after the pre-dilatation. We opened up the lesion. So we decided to, since both the vessels were big, we decided to do a DK crush for this. So for this case, we decided to take both as Elnir actually. So the first one, we kept a balloon in the LAD, and with the balloon in the LAD, we stented the diagonal. This is where I think Elnir helped us again, because we knew exactly as to how much of the struts, how many struts are actually going out, because this patient could not afford imaging, so we couldn't use imaging. So we were going to keep the number of struts into the LAD to be perfect. So we took a shot before this and placed the stent. Because of the marker, we were able to show how many struts were there, and then followed by crushing it. Then we recrossed again, and then this is a shot after recrossing. And then we gave a kiss. This was the first kiss with both the balloons in LED and D1. This was a shot after the first kiss. Then we went ahead, put the second Elnir into the LED across the diagonal. So this is the other good part where we get to see, if you look at it, you'll know after crushing as to how much of the stent has been crushed because of the markers. They get pushed to one side actually. So you realize that the stent has been crushed enough for you to cross over. And this is after placing the second stent. Took a shot, removed the wire, recrossed again. Oh, sorry, this is the shot after the missing. We post dilated the LED, did a pot, followed by recrossing into the diagonal after that. All right. So, but after this, we had a little trouble. Actually, we were finding it difficult to pass a balloon into the diagonal. So we had to take a smaller 1 millimeter balloon first to cross into the diagonal. And after that, we dilated with a 2. And then we did another, and then took the bigger one, 3. And then we did the second kissing after that. And after the kissing, we had a pretty good flow through and through. So this was the final shot after the wire. And as you can see, the crushed stent, the markers have been pushed to the edge of the wall of the main vessel actually. So that clearly proves how much was being crushed, and that gives us your feeling that okay, we've crushed enough and it's stuck to one side of the stent. And that is where I think Elnur helps also. So we can actually figure out how many struts, even without the imaging, we know how many struts are in the main vessel and the branch and decide how to crush it. So the crushing is seen better because it's been pushed to one side. As I said, we had a little difficulty in passing the balloon. I'm not sure if it is because we didn't get the proximal event distal because we didn't have imaging. We're not very sure. And yeah, we'll have to wait to see how this stent works because it's a uh, new platform. We need to see how much does it work? Is there any ISR or something of that sort? Thank you.
So I guess again a very good case followed by following proper steps for the DK crush. And the result, even at the time of post DK crush, looks fine. But with the two stents, we have to be skeptical about the future outcomes. I think imaging would have further given us some idea, although the studs are going to help you marker, and it reduces the requirement of imaging in this case. So if some questions are there, we can take, or we can go for the next case.
I
Ritik?
just wanted to ask you one question, Dr. Samuel. Nicely done case, no doubt. Steps were beautifully followed. What made you think of choosing DK crush over doing a kilot or mini kilot in this patient? Because considering the angle of the vessel, don't you think it would have been much easier for you doing a mini kilot, and considering the type of stent it is, where you can easily dilate the side branch is already there, and easily you can dilate a stent and go across and put a new stent over it.
So yeah, I was actually stuck because of the thing, but since both the vessels were quite big, actually, as I said, both of them are big. I didn't want to take a risk with anything, and as most of the studies have always shown, the DK crush has a superior to a mini kilot. I didn't want to take a risk. That's all. I just thought, okay, I'll just
Because
take
considering the angle, because what is
angle. I
happening in
know.
DK crush, sometimes it's difficult to cross, as you felt
Also,
it. But
yeah.
in many kilot, the idea would have been you've already got a stent in the side branch, so it doesn't even matter if you would cross it or not. But I don't think with this stent there should be a problem crossing either way,
Also,
considering the open cell design and the way
should be,
it is.
yeah.
Yes, so.
True.
Anyways,
I think
nice
Dr.
case, no
Ripin
doubt.
sir has some
Wonderfully.
inputs to give, I guess.
No. I think it is a nicely done case. Good result. Yeah.
Sir. So can we move for the next case by Dr. Raj Gopal, Avant BKG Hospital, Karnataka?
Hi.
Please share the screen. Yes, thank you. We
Yes.
can see them.
Am I visible?
Yeah, they are visible on the presentation.
Thank you. Thanks for taking me on this nice meeting. And I have been using Elnir for a past few months. Of course, stent designs have stagnated for past few decades, from the Parmaschat stent and up to the bioabsorbable scaffolds, which have gone in and out. But I think the Elnir Pearl has come in as a refreshing change. There is something which the others do not have. The case I'm presenting is a middle-aged male, recent onset angina, strongly pursued TMT, significant single vessel disease of LAD-T1, Medina 111. It's just a bifurcation, just like the previous. There is, in addition, a second vessel which is coming there. It's a little complex bifurcation, moderate calcium. Both the diagonals are quite big, but the second diagonal seems to be having three branches. First diagonal, the ostium is fine. So we decided to do a bifurcation with the second diagonal. We'll do the IVUS and then decide whether something has to be done for the first diagonal or not. So this is the in every view, the first diagonal does not appear to have any much disease. So we went ahead. The IVUS initially didn't go, so we decided we do a pre-dilatation. So did a pre-dilatation for the vessel, both the LAD and the diagonal. Then did the IVUS. The IVUS run showed that it was predominantly fibrophatic with 180 degrees of calcification. And the LAD calcification was before the bifurcation. The ostium of the LAD was diseased. The distal landing zone was just after the D2, means the vessel rapidly becomes 2.5 mm from 3 mm. And the disease is extending up the ostium. The left main is free of disease. The diagonal D1 was free of disease. So we decided to go ahead with the LAD D2, that is mini crushed. So we took after the pre-dilatation, we took the Elnir stent, the 275 into 24 for the D2. You can see that the markers are helping us in positioning it very nicely, exactly where we want it to be. I didn't want it to come too much inside, otherwise the D1 may get into the struts may get into the D1. So we used mini crush on this. So once the stent got deployed, then we brushed it, the 3 mm balloon, then took a 3 into 28 Elnir Pearl. As the IVS had predicted, the landing zone had to be perfect. Otherwise, there was a muzzle bridge and the vessel was tapering down. Then the ostial positioning was also confirmed. The markers help a lot in the ostial positioning. Then once the stent was deployed, we did a crossover, then kissing, then post dilatation and port. This is the final result. You can see that both the markers, the D1 marker is in the LED. The crush has happened well. The result appears very nice, and the distal vessel is very, very nicely tapered. So the new stent platform is quite unique and it's quite trackable, very good conformable. The markers on the balloon and stent are quite useful in exact position of the stent, especially in the ostium and bifurcations. A bit more trackability for longer stent lengths may help. And longer stent lengths, if it is there, maybe it will be quite good because the stent is quite it's a new design and it's quite good. Balloon overhang is slightly more. Maybe we can reduce the balloon overhang a little bit. It appears a little bit longer overhang than the other stents. Thanks for your time.
Another good case. The only thing is that although the argument may be the diagonal is quite big size, I usually prefer in these kind of cases, usually we do a bed preparation for the diagonal with maybe a cutting balloon. I don't find any significant dissection or something, I would have preferred an Elnir Pearl and LED and maybe a Protease in the diagonal, if anybody agrees with me, because in a LED diagonal bifurcation, left-hand bifurcation, yes, the Ramus LED, the previous ones, LED diagonal, usually I try to avoid two stents because of the risk of restenosis. And if we have an acceptable result, I think we could have done with a drug balloon. That is my alternate choice for the case.
No, initially the plan was the same, but after the balloon dilatation with a 1:1 balloon, there was a significant dissection there. There was quite a bit of calcium also. So I was quite afraid of the recoil and maybe dissection may become more. That's the reason
Preparation was done with which balloon? That is important. The diagonal preparation.
Balloon. Definitely, it was a MC
because
balloon.
if it's a fibrotic or calcific, you need either a cutting balloon or scoring balloon or something.
Calcium was not too bad, but it was calcium was there, 180 degrees.
It's always the operator's choice what level of dissection you accept and you leave it. So, but anyway, end result is perfect. I think Dr. Raghav has some question.
No, I correctly agree with Dr. Raj Gopal. I have faced this problem with drug-coated balloons sometimes when even though you do a very good preparation, I have seen the recoil and sometimes you land up in trouble when you are going because already you put a stent in LED and you have done a drug-coated balloon in the side branch, then it becomes a big chaos, recrossing it, creating further extending the dissection. So I think idea is to get an excellent result and bail out the patient in whatever way, whichever method is suitable, and it's excellently done case, very nicely dilated and perfectly done. Should not have problems. Of course, antiplatelets has to be taken properly, and how compliant the patient is, that question does come. As you rightly said, chances of ISR do increase. But it's a beautifully done case, no doubt about that.
The
Nicely
final
done.
result acceptable, perfectly fine and done with the imaging. So I accept it's a very good result. The only thing, an alternate method I'm telling about that we are usually doing it now for the side branch, particularly diagonals, not the LED circumflex bifurcation.
Suppose it's less than 2.5. If it's 2.5 or less than that, I don't stent it. But this was significantly bigger.
It was a sizable. I agree with you. It was a sizable LED.
That's the only
Yes.
reason. I think it's
Nice
both
case,
choices
I
are
would
okay.
say. Yeah,
Thank you, sir.
perfect case with the Elnir. I think we can go with next case with Dr. Vidur Karnik from Hridayam Hospital, Kolhapur.
Yeah. Good evening. Okay. Am I audible and visible?
You're audible. Now you can put it on a presentation mode.
Yeah, wait. Fine?
Yeah, it's now on presentation mode. Good to go.
Yeah. Good evening. we'll little bit discuss today regarding the Ilnir Pearl and the mini crush PCI for a left main. Here the patient profile. My patient is 53-year-old male, chronic smoker, recently diagnosed as a diabetes, hypertension, and CKD. CKD 4, stage 4. The EGFR is about 18 ml per minute, and the creatinine was 4.5. The index event was the 8 days back. Patients having chest pain, acute inferior MI, thrombolytes with tenecteplase, and referred further for coronary angiogram. So, doing our admission, patient status is chest pain relieved, hemodynamically stable, no heart failure. Echocardiography shows global LV hypokinesia, LV ejection fraction is almost about 30 to 35%. Walls are good, sclerotic aortic wall, MAC, and the IVC is partially congested. So in this case, the clinical challenge is severe LV dysfunction, advanced CKD, and the high risk for the contrast-induced nephropathy and high surgical risk. The coronary angiogram performed with minimal contrast, showing triple vessel disease, left main, distal left main, osteoproximal and mid LAD significant lesion, and L6 proximal lesion. So Medina 111. Also, the RCA is proximally significant lesion. Here we can see the angiogram. Here see the RCA, proximal RCA tight lesion, and also the sorry, here we can see the RCA lesion, proximal RCA tight lesion, and distal RCA near precrux. There is also disease. And here in LAD, we can see here a distal LMCA deceased, proximal L6 also deceased, and LAD proximal as well as mid LAD, the significant lesion is there. And we can here clearly see the tight calcium or the heavy calcium is seen. So the plan was the first is whether it is go for optimal medical management, and the first choice is CABG and versus multivessel PCI. But with heart team discussion, CABG is rejected by cardiac surgeons. The reason is the advanced CKD and the severe LV dysfunction. So the decision is the PCI. So what we did, the first did RCA. RCA is quite okay. We go directly direct stenting with 3 into 38 Elnir. Here we can see stenting done, and the result is very good. Then we go for the LAD. First mid LAD done. We prepare the bed nicely with 2.5 into 15, and after that the mid LAD 2.75 into 33 Elnur stenting was done. After that, we go for the bifurcation stenting. Here 2 wires kept, the workhorse wires like cyan blue and Fiddler FC. Then we go with the mini crest. So the side branch is the L6. So first we did, here we can see, first L6 stent was deployed. Then that is crushed by LAD. After that we did pot. After pot we go with the double kissing here. 3.5 into 15 balloon used for both, and again the final pot that is 5, and see the result. The TIMI3 flow, the patient is asymptomatic. So whatever the strategy like multi-vessel PCI was planned, that is performed, and the renal protection with ultra low contrast was done, and the successful stent deployment final TIMI-3 flow achieved, and there is no procedural complication also. So the take-home message is the pharmacology strategy works. CABG is not always feasible in CKD with LV dysfunction, and complex PCI can be done with planning. And all 4 stents are Elnir Pearl, and that is very good result.
Was there any need for a renal replacement therapy post-procedure?
That is routine, like fluids and everything is managed.
Was there any
He's
need
asking
for
maybe
renal
need a
replacement therapy?
dialysis or something.
No. Patient is absolutely normal. After 2 days of procedure, surprisingly, creatinine was comes down with 3.2. Outputs are good, and patient is
My 2 questions. One is, did we do a viability because patient was pain-free with an LVF of 35%? Whether we needed all 4 or we could leave one, even if you are going for PCI rather than surgery.
Yeah. Well, first thing was that only, but on echo there is no scarring, and the patient was inferior wall myocardial infarction recently 7 days back, and 53 years male. So total revascularization is the choice.
Scarring may take 4 or 6 weeks, but anyway, if you are going for 4 stents in a CKD patient, I would have gone for a PET scan. That is one thing. Second thing, without any imaging, particularly IVUS. So when we label ultra low contrast PCI, if you are actually doing that, so then using a 2-entry TOHI with 2 wires simultaneously to place the stents under just IVUS guidance rather than using contrast. Imaging is one thing which should have been done if we are doing a left-band bifurcation. RCA is acceptable, but without imaging the left-band bifurcation, I mean, I don't know how much accurate we are just with and that too with a very minimum contrast I have seen here. So there are 2 questions. Otherwise, angiographical result is fine, perfectly fine.
The financial constraint was there, though IVUS or imaging was not done, and contrast almost about 170 ml was used.
170 ml contrast, I will not label it as ultra low contrast PCI, because if you use it with an IVUS and a proper 2-entry TOHI, it will be 40 ml contrast for a left man and RCA PCI, to be very honest. So these are but anyway, if we have constraints, we also know that in all patients we cannot do imaging. So this stent saves your life with the markers. That is another take home from the presentations we are seeing, bifurcations particularly. So nice case. May I invite Dr. Hitesh Shah from Rajasthan Hospital, Ahmedabad, for next case?
Yeah, good evening, everyone. Can you share
Good
the
evening,
slides
sir.
from the
Yeah,
can you share
so
the
should
slides
I
from
share the slides?
Yeah, yes, because there is some technical glitch in my because
Okay,
I'm
fine.
So Ritesh, share the slides for
Yeah.
Dr. Hitesh.
Yeah, good evening, everyone. And with excellent presentation of Dr. Ham and all the other speaker, I have the very simpler case just to where I use the alluminum stent. It was not much of the complex lesions, but the thing is because of that marker and the precision in the positioning, in this case was selected. Otherwise, it was a simple case. Next slide, please. First case was 51-year-old man, pain with distant SCS, inferior infarction with ongoing angina, and he was in triple vessel disease. Next slide, please. Ejection fraction was 45-50% with inferior territory hypokinesia, infraposterior wall. LAD was showing borderline lesion, so we left the LAD, and LCX was 95 ulcerated lesion in the proximal part, and RC was a 90% lesion in the distal part. Next slide. So we stented both LCX and RCA. LCX was with another different stent, and RCA with the 320 Elunir. Next slide, please. Can you run if possible? Yes. So this was the what seems L6 lesion. Next slide. Next one. Next one. Pre-dilatation. Next. Next. Next slide. It was bit fibrotic calcific lesion, so this was another stent, but we could make with a non-compliant balloon and to give the final result with good L6 stent apposition and everything. But we anticipated, we didn't use L-linear in this LCX, but with the vessel morphology, we anticipated some trouble in RCA. Next slide. Next slide. Yeah, run this. Yeah, this was the final result. Now show the RCA, please. Next slide. So this is the lesion in the RCA, and there was a bit of proximal tortuosity also, and we because there was plaquing, some diffuse plaquing inside the RCA, so we wanted accurate precision stent placement. Next slide. This is again pre-dilatation. Next slide. Next slide. This is how the stent was placed and deployed. Next slide. There was excellent apposition of the stent, and in the contrary to our anticipation that it will behave like in terms of expansion, but it well expanded with minimal efforts in the post dilatation. We could get the very good results. Next slide. Things which I wanted to point is like because of the marker, the positioning in the tortuous vessel, it was like good. And again, this patient because he was ongoing angina and he has a little mild hemodynamic compromise, so we wanted to finish the procedure as fast as possible with the minimal contrast. So things went well, and this was the final RCA image. Next slide. This is standard recommend. Next slide. Another case was 66 years old male with STEMI and with again mild left ventricular failure, non-case of COPD and hypertension. Next slide. Again, it was a long LED lesion. We stented with the two stents. One of it was L-linear, and it was at the ostial LED positioning. So again, the marker helped us. That's why we choose this case to show. Next slide. Can you run this, please? So this is where the lesion was looking like. It was nasty. There were multiple plaques and critical lesion. Next slide. There was diagonal involvement, but we just did the diagonal ballooning in this case, not the dedicated bifurcation stent. Next slide. Then deploy the one stent in the mid distal LAD. Next slide. That was another stent. That was different stent. Next slide. Sweeping the diagonal wire. Next slide. Patient was a bit unstable in between, so we wanted to quickly finish off the procedure. Next slide. This was a post dilatation in the mid distal stent. Next. Then this is the proximal stent keeping the diagonal wire. We saw that L-linear 3.5 by 24. Next slide. Again, the markers help us to position well because we didn't have facility of imaging in this case, but we could do well. It was well a post stent with a in ostial location, perfectly positions and without any compromise. Next slide. So message is like the markers and the way the deliverability and we can hold with the expansion profile and radial stand. It is excellent in terms of this lunar pulse stand, and we have a good what with limited experience like we just use in last couple of months only, but it was excellent to use and in precise location as well in the ostial positioning. Thank you.
I guess nice.
When you are doing the overlapping stent, you overlapped on the marker or left the marker?
We overlapped on the marker because the marker, which is what they propose, is just one strut behind the actually edge of the stent. That is what where the design of the stent is. So it was for ostium, it was just at the marker, and at overlapping the stent, it was just inside the marker. So that because the mid distal LED stent was 3 and the ostial stent was 3.5 in size. So anyhow, we wanted some overlap, some more overlap, in fact, so that in post dilatation we do not have any more issues.
So I guess Dr. Sam has a question in the chat box that do we see any longitudinal foreshortening as we see with the other stents? So I have not seen so far. Whatever we have used, so no significant foreshortening as used to be with Promus element, to be very honest. And then the Elite and this all, they eliminated that soft nature of the stent. And another thing, I think the angiographic result was perfect here. You could have used a stent balloon also if you have in your lab, Dr. Hitesh. So if you had a stent boost, you can again reconfirm if you are not using two Elunir. So boost, I guess you could easily see the overlapping segment. Ostial, yes, we will confirm with the markers. And a little slow flow was there if you see if you deployed the ostial element because there's a lot of
But that
burden.
last image was it was very thrombotic lesion, and there was like as you can see in the angiographic picture, there were multiple ulcerated plaques in the proximal to mid LED. But we could
So
deal
we
with that
usually now in
because
these all
that last
cases
image
use
is not, but we gave the intracoronary nicorandil nitro everything, and final result was good with T3
Yes,
flow both in LED and diagonal.
final result is perfect, but we usually prefer in these kind of lesions the Cangrelor 1 during the procedure and intracoronary adenosine. Another thing, we find an excellent one, and we usually pre-treat these lesions with the pre-vasodilators and particularly adenosine. But nice case, nicely done, and excellent result, just nailing the ostium. We are open for discussion. We have another question from Dr. Sam only. That when overlapping, do you keep the marker on marker or do you keep a little more overlap? So I guess with marker, I think Dr. Ripin will enlighten us on the overlapping with Elunir.
Yeah, I think a little bit more. I will be more comfortable because the artery is always not, you can say this could be a angulated artery. So I always keep a margin of safety. So I think we should not be on the marker. Slightly in is better, always better.
So I've seen one in another institute, sir. Just 2 mm gap into stents, and exactly there we have a ring-like lesion. After
Yeah.
6 years of the excellent result of primary angioplasty, I mean first angioplasty. So you are correct. So leaving us bare area in between two stents is not prudent. So everybody is open for the discussion before we close. And I hand over it to Ritik. So Ritik, you can proceed from here.
Yes. So I guess Dr. Dannenberg have to be left due to certain emergency. So any final comments from Dr. Ramesh, Dr. Anmol, Dr. Raghav, sorry.
So I guess we have
Electrical
no
is
question.
particularly very useful for this ostial exact position when particularly when there is a issue of finance where I was you are not very because of the finance constraint. If you are not using IVAS, I feel this is a very becomes very handy. And particularly when we are putting these overlapping stents also, then these markers will help you in proper positioning of stents. And being a thin stent, I think the trackability also is good, particularly where they showed that very tortuous RCA was stented. So I think that is my take home from the stent.
So I think we have a new tool on our cath lab shelf, and more we use, we will have pros and cons of the device. So I hope we will have more and more use of this device. So if everybody's okay, I'll take your leave.
Yes, we can wind up, sir. And thank you everyone for joining this amazing webinar and sharing your thoughts on Elunir Pearl and how this technology will be helpful in future for all the patients. So thank you everyone.
Thank you. Good night.
Yeah. Good night.